When you push an athlete's leg toward their chest in a static stretch, you are treating their body like a simple rubber band. On the left, we see a passive limb hinge, but on the right, look at the active electrical firing of a facilitated PNF stretch. This active approach is called proprioceptive neuromuscular facilitation, or PNF. In the 1940s and 50s, physical therapists developed these precise techniques to rehabilitate severe neurological conditions like polio and multiple sclerosis. Over the following decades, practitioners realized that a system designed to rebuild shattered nervous systems demonstrated consistent success in upgrading healthy systems, making PNF a cornerstone in modern athletic training and sports medicine. The flaw in standard passive static stretching is that it treats the human body like a purely mechanical object. It completely ignores the central nervous system that dictates the tension and length of the physical tissues. Creating lasting mobility requires a shift in focus from the physical hardware to the neurological software controlling it. By integrating highly specific, active isometric contractions before the stretch, we can override the body's natural defensive stretch reflexes that lock up tight joints. These targeted neurological inputs force the nervous system to safely and permanently upgrade the patient's active motor control, far exceeding the effects of temporary tissue elongation. To see exactly how this software hack works, we have to look inside the microscopic architecture of a muscle tendon unit under tension. Tissue length is dictated by two primary proprioceptors. The muscle spindle detects the rate of the stretch, slamming the brakes if you move too fast. The Golgi tendon organ, or GTO, monitors overall physical tension. For decades, the standard textbook theory was autogenic inhibition. The logic was that if you performed a hard isometric contraction, the GTO would detect dangerous levels of tension and force the muscle to relax to protect itself. Clinicians also relied on reciprocal inhibition, the premise that contracting an opposing muscle automatically shuts off the target muscle on the other side of the joint. But modern clinical data paints a different picture. Current scientific consensus shows that these exact reflex inhibitions do not reliably occur in the way they were originally taught. Instead, the rapid gains from PNF come from two distinct mechanisms. First, the intense load physically changes the fluid properties of the tissue, altering the muscle's viscoelasticity. Second, and more importantly, it alters stretch tolerance. The central nervous system effectively recalibrates at the cortical level, increasing its threshold for what it perceives as a painful threat. An isometric contraction before a stretch doesn't just mechanically shut down a local spinal reflex. It negotiates directly with the brain to tolerate a new, deeper range of motion. To trigger that negotiation in a clinical setting requires a precise protocol. Historically, therapists relied on the contract-relax method, where a target muscle is contracted against resistance before the practitioner pushes the limb further into a stretch. Clinical practice has since evolved into a more demanding, active form of facilitated stretching, known as the HRAC sequence: hold, relax, agonist, contract. This diagnostic visualization tracks the HRAC sequence in real time. In step 1, the hold, the practitioner positions the limb and the patient executes a precise isometric contraction against optimal resistance. Step 2 is the relax. The patient completely releases the tension, entering a brief physiological window of modified viscoelasticity. Then comes step 3, the agonist contract. Instead of the therapist passively pushing the limb further, the patient actively fires their opposing muscles, pulling themselves into the newly acquired range of motion. By removing the passive push of the therapist in that final step, HRAC forces the patient's nervous system to claim ownership of the new space. Applying this sequence to a single-plane stretch, like a straight leg raise, is effective, but human functional movement is rarely perfectly linear. Maximizing the neurological effect requires mapping the stretch to the specific functional architecture of the human motor cortex, which operates in spiral and diagonal pathways known as Kabat patterns. This technical diagram illustrates the geometric mapping of these diagonal movement tracks across the human body. Notice how the pathways form intersecting lines. A sequence like flexion, adduction, and external rotation demands a complex multiplanar contraction rather than isolating a single joint. Engaging these specific diagonals activates two specific physiological processes: irradiation and reinforcement. When a therapist applies optimal manual resistance along these precise diagonal tracks, The muscle activation spreads from distal joints, like the hand or foot, straight up into the core, systematically recruiting synergistic muscle groups. PNF patterns replicate our exact neurological wiring, allowing us to use the strength of the whole body to reinforce the flexibility of a single joint. Beyond the mechanics of angles and resistance, the true efficacy of facilitated stretching relies on how the patient learns the movement over time. Mastering a new range of motion requires progressing through 3 distinct phases of motor learning. It starts in the cognitive phase. Here, the patient relies heavily on the therapist's manual contact, verbal cues, and applied resistance just to figure out the mechanics of the movement. Through repetition, they reach the autonomic phase. Now, the patient can access this new functional movement entirely on their own, even while their brain is distracted by a dual-task environment, like walking or playing a sport. This progression highlights a critical philosophical imperative in physical therapy. Purely passive treatments inherently encourage the patient to become dependent on the practitioner. Because HRAC stretching is active and requires high physical effort, it forces the motor cortex to effectively save the file, ensuring the patient learns to generate the mobility themselves. Facilitated stretching serves as an active recalibration performed in partnership with the patient, granting them the tools for permanent physical independence.